Good afternoon. My name is Matthew Clay, and I'm with JBS International. Thank you for joining us for today's webinar, Prescribing in a Post-Waiver World, Expanding Access to MOUD and Implications of 42 CFR Part 8 Revisions. Before we begin, I'd like to review some housekeeping items. Due to the high number of participants on this call, all participant lines will be muted for the duration of this webinar session. If you have any comments or questions, please submit them at any time by using the Q&A window. To open your Q&A window, click on the Q&A icon that's located in the bottom center of your Zoom window. Closed captioning is also available. To access closed captioning, click the Show Captions icon that's located on the bottom of your Zoom screen. To access the live transcript, click the link located in the chat. If you experience any technical issues during this webinar, please message us using the chat feature, which is located at the bottom center of your screen, or email us at samhsastateta@jbsinternational.com. Lastly, this is a recorded event, and your participation grants consent to be recorded. The recorded webinar and PowerPoint slides will be made available and sent to participants at a later date. Next slide. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. Next slide. At this time, I will introduce our speakers for today's webinar. Dr. Ingvild Olsen serves as the director of the Center for Substance Abuse Treatment at SAMHSA. She has a long history of working within the addiction treatment field to expand access to care and enhance quality. Dr. Olsen began her career as the medical director for the Johns Hopkins Hospital's outpatient substance use treatment services, while a full-time assistant professor in the Department of Medicine at the Johns Hopkins School of Medicine. She subsequently served as the deputy health officer for Maryland's Harford County Health Department, where she led a modernization of publicly funded substance use treatment services in collaboration with state and local partners. She next served as the vice president of clinical affairs for the Baltimore Substance Abuse Systems, then the local addiction authority for Baltimore City. Dr. Olsen has also served as a medical consultant to the Maryland Behavioral Health Administration, as a clinical expert to the Maryland Addiction Consultation Service at the University of Maryland School of Medicine, and as an advisor on addiction interventions to the Baltimore City Health Department. From 2011 to 2021, she served as medical director for the Institutes for Behavioral Resources, Reach Health Services, a comprehensive outpatient substance use disorder treatment program in Baltimore City. Next, James Anderson has been a physician associate since 2000. He currently works in Seattle at Evergreen Treatment Services, a federally approved opioid treatment program. He's the current president of the AAPA Society of Physician Associates in Addiction Medicine and is a commissioner on the Washington State Medical Commission. A graduate of the University of Washington MEDEX Physician Associate Program, he holds a clinical faculty appointment with the University of Washington Department of Family Medicine. He's given presentations about addiction locally, regionally, and nationally, and has written extensively about addiction. He currently writes monthly blog posts for the Clinical Advisor publication. Deborah Fennell has specialized in mental health and addictions for the majority of her career. From her grounding as a registered nurse working in inpatient psychiatry, she expanded her role to that of a clinical nurse specialist and then a nurse practitioner. She brings her passion for the neurobiological basis of mental health and addictions to her clinical practice, teaching, research, and policy and advocacy. With funding from SAMHSA, Dr. Fennell led the integration of substance use-related content, including screening, brief intervention, and referral to treatment, into the nursing curricula at Johns Hopkins School of Nursing. She advocates for expanded access to mental health and substance use treatment, including calling for advanced practice nurses to prescribe buprenorphine. Over her decade with the Department of Veteran Affairs, Veterans Hospital Administration, She conducted funded research focusing on improving the health of veterans with mental and substance use disorders. Her professional leadership roles range from past chair of the New York State Peer Assistance Committee to past president of the International Nurses Society on Addictions. She served as chair of the Addictions Nursing Certification Board and also was a member of the Committee on Nursing Standards for the American Nurses Association. She currently serves on the board of the Association for Medical Education and Research in Substance Abuse and is associate editor of the organization's professional journal, Substance Use and Addiction Journal. Next slide. Unfortunately, Dr. Olson could not be with us this afternoon. However, she did record a welcome message along with a brief presentation that we will play for you now. And we may be experiencing a minor technical difficulty as the sound from Dr. Olson's video is not playing. So give us just a moment to fix that.
Hello, my name is Dr. Ingvild Olsen, and I serve as the Director for the Center for Substance Abuse Treatment within SAMHSA. It is my pleasure to welcome you to this webinar, one of several in our series of state TA webinars for single state authorities and others involved in implementing the Substance Use Prevention, Treatment, and Recovery Services Block Grant, or SUPTRS BG, as we affectionately like to call it. Today, I'd like to briefly describe to you several key policy changes that have happened over the past couple of years that have the potential to dramatically expand access to life-saving treatment for people with opioid use disorder. These historic changes come at a time that our country is still seeing over 100,000 deaths from overdoses every year, primarily driven by illicitly made fentanyl and its analogs. Now, what is so exciting to me as the CSET director and as an addiction medicine specialist physician and general internist about these policy changes is the opportunity not only to expand access to treatment, but these changes foster integration and inclusion of a workforce that is already practicing in many areas of the country, such as rural and frontier regions, and in clinical settings such as primary care and opioid treatment programs, where really more of their skills and knowledge could be harnessed for patient care. And given the behavioral health workforce shortages we know exist across the country, engaging primary care physicians, nurse practitioners, and physician assistants in the provision of medications for opioid use disorder in a variety of clinical settings has the potential to make a tremendous difference in our efforts to address the overdose crisis. So thank you for attending this webinar and for the work that you are and will be doing to ensure that people with opioid use disorder in your states and communities have the access to services that they need and deserve. So with that, let's try and, I'm going to try and share my screen and just provide you with a few remarks to get to set the stage. So, prescribing in a post-waiver world, expanding access to MOUD. So, as I mentioned, the United States continues to experience the most significant overdose crisis and substance use disorder epidemic that it has ever faced, exacerbated by COVID and driven by the proliferation of the synthetic opioid fentanyl and other analogs, but increasingly also in combination with other substances, particularly stimulants such as methamphetamine and cocaine. So in 2023, the CDC reported that more than 107,000 people lost their lives to overdose. Now, the good news is that this was a 3% reduction from 2022. And while we are cautiously optimistic that this trend might continue, we also want to make sure and we understand that a lot more work remains. And we know what can help. Medications for opioid disorder, particularly methadone and buprenorphine, have more than 20 years of evidence for their ability to reduce mortality from overdose and improve a host of other related outcomes, as you can see on this slide. And we also know that treatment with effective medications is not addiction by another means. Now, for over the past 20 years, however, prescribing buprenorphine for the treatment of opioid disorder required that a practitioner hold a special waiver from the DEA. And even with that, were held to limits on how many patients they could treat at any given time. That all changed in December of 2022 with the passage of the Consolidated Appropriations Act of 2023. The elimination of the need for that special waiver significantly expands the pool of potential buprenorphine prescribers from about 130,000 practitioners who were waived at the end of 2022 when that was still required, to include approximately 1.8 million DEA registered practitioners. So since this policy change, any practitioner with a valid state license to practice medicine and a current DEA authority to prescribe Schedule III medications may prescribe buprenorphine subject to applicable state law. Now, recognizing that most healthcare practitioners don't really receive sufficient training in the care of patients with substance use disorders, Congress also passed another provision in the Consolidated Appropriations Act of 2023 that established a one-time, non-recurring training requirement of at least 8 hours on all practitioners who are either newly or reapplying for their DEA registration. There are a couple of exceptions as to how people can otherwise meet this provision requirement, but the training is really the most common one. And this is a provision that went into effect in June of 2023. Now, in creating these provisions, however, Congress really did not specify the content of any substance use disorder training that may be required. So to help states, practitioners, and others better understand what might constitute recommended training, SAMHSA, with input from federal and external experts, developed recommendations for curricular elements in SUD training that can be found on our website, as you can see here. In addition, earlier this year, SAMHSA, in collaboration with the Office of National Drug Control Policy, released report guidance on core SUD curricular elements for early academic career professionals, with recommendations that are applicable to medical, physician assistant, nurse practitioner, nurse, social work, public health, and counseling academic programs. Now, the second major policy change that I wanted to tell you about that has the potential for expanding access to OUD treatment is one that SAMHSA released in February of 2024, related to how opioid treatment programs, or OTPs, deliver care. This is the first substantive change to the federal rules that set standards for services provided in these specialty clinical settings in over 20 years. And the changes SAMHSA made are grounded in data and lessons learned from the COVID-19 pandemic, when regulatory flexibilities for methadone were implemented to protect not only OTP providers, but also really their patients. And studies since then have shown that methadone-related overdose rates did not increase as a result of these flexibilities, and that methadone diversion was low among patients receiving expanded take-home doses under that flexibility. Now, the ongoing overdose crisis also really calls for patient-centered, accessible care that incorporates harm reduction principles and promotes the use of clinical judgment and person-centered care that removes the punitive approach to treatment that unfortunately still exists within OUD care. Now, we made a lot of changes to these rules, so I would encourage you to check out our website where you can find information about all of them. But I'd like to highlight some of the major ones. First, the final rule makes permanent the flexibilities for the provision of methadone take-home doses, including shifting the criteria for determining how many to provide a patient from what has historically been a rigid, rule-based framework to a clinical judgment-based one that clearly uses a risk and benefit approach, just like we do in other areas of medicine. In addition, the rule makes permanent the ability to start buprenorphine for OUD treatment via telehealth platforms, including audio only within OTPs. In addition, we've added the ability to initiate methadone using audiovisual telehealth platforms and provide for the ability of practitioners external to the OTP, such as primary care providers, a hospitalist, or an emergency medicine practitioner, to name a few, to conduct the medical screening exam that OTP practitioners can then review and confirm as another way of expediting starting methadone. In addition, we've made it simpler for people younger than 18 with OUD to access services in OTPs, added and clarified definitions such as split dosing to really support evidence-based care, and incorporated those harm reduction and recovery principles that we know are important to help patients stay alive and meet their goals, both in the short and long term for their chronic disease of OUD. Importantly, though, I want to note that the rule does not apply to prescribing methadone for the treatment of opiate use disorder outside of an OTP. Now, finally, we explicitly included nurse practitioners and physician assistants as practitioners that can practice to the top of their license and scopes of practice within the OTP as allowable under state law. And this means that states no longer need to submit exemption requests for these practitioners to manage all aspects of methadone and buprenorphine for patients within the OTP. Now, I do want to note that the medical director of the OTP still needs to be a physician, either an MD or a DO. We also have made changes to other aspects of OUD care, whether in medication or mobile units, through interim treatment, or in long-term care or in correctional settings. Now, undergirding all of these changes really is a vision for changing the culture of care and service delivery in OTPs. The goal is for these changes to foster trust and recovery in a patient-centered environment, acknowledge the skill and patient-centered understanding of treating practitioners, whether those are physicians, nurse practitioners, or physician's assistants, and as part of a multidisciplinary team with social workers, addiction counselors, peer recovery specialists, nurses, medical assistants, and lab technicians, really all working together for the benefit of the patients they serve. At the end of the day, these changes are meant to support the creation of responsive, flexible OTP services that are grounded in evidence and that promote medications for opioid use disorder as a treatment for a chronic medical condition in a non-stigmatizing environment. Because unfortunately, the challenge of stigma is still a huge barrier for people. Research and clinical experience show that people with substance use disorders are less likely to seek treatment and more likely to drop out of care if they expect or have experienced stigma in other settings, especially in settings or from healthcare providers that purport to be helping and caring for people, even when those people and when those healthcare settings, and especially when those healthcare settings and providers are specialty addiction treatment facilities. And nowhere has this stigma been more visible than in the treatment of opioid use disorder with medications. I am really hopeful, though, that with the policy changes we've reviewed today, more education and better understanding of substance use disorders, including OUD, as chronic conditions with opportunities and demonstration of recovery, that we may be turning the tide on stigma. Your participation and work in this area is part of that process. So I just want to thank you all for all you do to help save lives and give people another chance at making positive change for themselves and their families. And thank you for being here.
All right, we'll now go to our next slide. And I'll now turn the floor to James Anderson to begin our subject matter expert presentations. James, the floor is yours.
Thank you so much. And thank you, Dr. Ingvold for in absentia for that a really good slide presentation. I really appreciated it. And next slide, please. So that's me. Blah blah blah. I would say that something here that's not accurate is I no longer work at Evergreen Treatment Services, which is the OTP where I worked for many years, and I love it dearly, but I no longer work there. And so, next slide, please. So I was really blessed to be part of the work group who looked at 42 CFR and looked at changing it and creating a final rule. And I can't believe how fortunate I was. The people there were the smartest people in the world, and I was like, how did I get on this group? But I did, and it was really great. So the changes, I think, are I would call them transformational as far as being able to provide more care for people with opioid use disorder. And I am still blown away by the changes that we came up with, and that's great. Next slide, please. So I've always been an incrementalist in my life as far as, I don't know, medicine and politics. I'm a PA, and but this has been a very incremental thing as far as the progression of increasing access to medications for opioid use disorder, and I'm very excited about that. The new regulations clearly define OUD as a medical disorder, which is, of course, we know that's what it is. Although when I've spent some time looking back at the early days of the use of methadone for OUD, and it's unbelievable that how little has changed since the 60s, but this changed it, and COVID changed it. It's unbelievable how the COVID-19 era provided unbelievable opportunities. And so some of the changes that have been undeniable, that there's no reason we should have made these changes a long time ago, but COVID-19 allowed us to actually do that. COVID-19 provided the incentive to be able to make some of these changes, and some of the new rules. They brought forth several things, including telehealth. They've also brought forth the increased ability for PAs and NPs and pharmacists to together be able to provide a better care for patients. And next slide, please. Actually, let's go back one slide, sorry. So one of the things that's been the most amazing thing to me about these changes has been the way that PAs and NPs and pharmacists are now able to provide more care for patients, and in ways that we were not able to provide that care before. For example, before the new rules, which came into effect on April 2nd. PAs and NPs, in order to be able to order the dispensation of methadone in opioid treatment programs, had to go through this incredibly difficult process where we had to get, we and our clinics had to get a waiver to saying, well, the rules say MDs only, but if you want PAs and NPs and pharmacists to be involved, then you have to get a waiver. And the waiver was extremely cumbersome for clinics. In fact, driving some clinics away from the use of PAs and NPs. And so the new rules, which came into effect on April 2nd, have changed the entire ballgame. And it's open things up much wider to providing more care, which can be provided by PAs and NPs using medications like methadone and Suboxone for opioid use disorder. So it's really a new day, and I'm very excited to have been part of that. So next slide, please, and Deborah, take it.
Thank you, Jen. Deb, the floor is yours.
Thanks. I think Matt's introduction of me, his kind introduction, really covered a lot of these things in terms of my credentials and my clinical academic experience and my professional society work with the Association of Multidisciplinary Education Research and Substance Use and Addiction, also known as AMERSA. My current role there is president, and I have been past president of International Nurses Society and Addictions and a former chair of the Addictions Nursing Certification Board. Next slide, please. So this is just a smattering of some of the publications that I've had that show that my scholarly focus has primarily been on advancing substance use related education for the future and the current nursing workforce. As mentioned at the beginning, while I was at Johns Hopkins School of Nursing and with continuous funding from SAMHSA, I led the integration of substance use content in pre-licensure and graduate nursing curricula, and some of those publications are shown here. It was important for us to really encourage and promote other nurse educators across the US to undertake similar curricular enhancements. And so we, in our publications, provided concrete examples of our processes and specific course content. I'm currently mentoring nursing faculty at the University of Buffalo in similar curricular enhancements to ensure that the Doctor of Nursing practice students receive the essential substance use related content to meet the current curriculum, and I had the honor of serving as an expert panelist on that work. While recent efforts have focused on educating future nursing, I recognized also the need to focus on the current nursing workforce. We know that from the literature, this content in curricula has been lagging for many of the healthcare disciplines. So I led the publication of core SUD related competencies for the generalist and for the graduate nurses. And then with colleagues who developed similar competencies for medicine, pharmacy, physician associates, and social work, I led a project in which those multidisciplinary substance use disorder competencies were aligned in to an online course. Next slide, please. Another focus of mine is advocating for and promoting nurses to practice at the top of their license. we know that registered nurses have key roles in substance use treatment, and Dr. Olson mentioned this in her opening remarks. The results of the primary care opioid use disorders treatment or PROUD trial conveyed the benefits of integrating nurse care managers into primary care-based treatment for persons with opioid use disorder. Our invited commentary in JAMA Internal Medicine underscores the importance for all nurses to have the knowledge, skills, and attitudes to care for this population. My colleagues and I at Johns Hopkins also documented on emergency nursing practice, providing best practices for screening, brief intervention, pharmacotherapy, referral to treatment, and follow-up and monitoring to more effectively care for persons with opioid use, opioid withdrawal, and those who are at risk for opioid overdose. And then lastly, my colleagues from the American Academy of Nursing and I published on the continued opportunities for advanced practice nursing since the removal of the X-waiver. Our policy paper in Nursing Outlook emphasized the need for full practice authority for advanced practice registered nurses, equitable reimbursement for addiction treatment, and increasing access to medication treatment for people with opioid use disorder. Next slide, please. So I'd like to take the opportunity in forums such as this to provide the opportunity to discuss the full complement of advanced practice registered nurses, or APRNs. So the categories shown here are the different roles of the advanced practice registered nurse: the nurse practitioner, clinical nurse specialist, certified nurse midwife, certified registered nurse anesthetist. Despite the national standards for education and clinical preparation, each state regulates the practice of the APRN, ranging from independent practice to reduced practice to restricted practice. With reduced or restricted practice, this means that APRNs are not able to provide patient care to the full extent of their education and clinical preparation, and thus prevents them from practicing at their fullest potential, limiting their clinical impact and their value. Next slide, please. So I'd like to show this map to illustrate this is illustrating nurse practitioner practice and how it's regulated across the United States practice environment. Practice environment data are available for the clinical nurse specialist, the certified nurse anesthetist, and the certified nurse midwife, which show similar disparities. States in which nurse practitioners have full practice are noted in green on this map. And full practice means that nurse practitioners can evaluate patients, they can diagnose, order, and interpret diagnostic tests, and initiate and manage treatments and prescribe medications, including those that are controlled. All of that occurs under the exclusive licensure authority of the State Board of Nursing. Reduced practice states noted here in yellow on this map, and restricted practice states noted that the nurse practitioner is prevented from practicing at their fullest potential. So despite being eligible to register with the Drug Enforcement Agency to prescribe controlled medications, including buprenorphine, APRNs in many states cannot. Several of those reduced and restricted practice states have the highest drug overdose mortality in the United States. Tennessee, I'll note, was one of the last states to allow nurse practitioners to prescribe buprenorphine, albeit with many conditions. Matt, I'll turn it back to you.
Thank you, Deb. We'll now begin our Q&A with our panelists. Next question, or next slide. Our first question: How does the elimination of the X-waiver create opportunity for states, jurisdictions, tribes to increase the number of substance use disorder practitioners? James, we'll start with you.
Sure. Well, it seems a little obvious. The X-waiver was just another obstacle. The Suboxone has always been a Schedule 3. Well, it is now a Schedule 3 medication, and so I think this is just another example of the incremental changes that have taken place to allow increased utilization of PAs, NPs, and the nurses that Deb just so nicely described. So now, like any PA, any nurse practitioner, when they come out out of school, they now are able to prescribe Suboxone. Of course, they can't prescribe methadone because of these crazy regulations. I mean, methadone can be prescribed for pain, but it cannot be prescribed for treatment of addiction, which is pretty weird, I think. But as far as the X-waiver, PAs, NPs, and the spectrum of nurses that Deb just described can now actually prescribe Suboxone, and that's a good thing. But the restrictions on methadone, I think, still need to be addressed.
Thanks, Jim. Deb?
So I think importantly, the elimination of the X-waiver really sends the message that all DEA registrants need to step up to address the opioid overdose and opioid prevalence that we have in this country for opioid use disorder. We do know that there are over 75,000 advanced practice registered nurses that are currently employed in the United States. And according to the American Academy of Nurse Practitioners, that group represents approximately 1 in 4 providers in rural practices where distance to treatment is a key barrier, particularly for vulnerable populations. While the X-waiver was in place following the passage of the Comprehensive Addiction and Recovery Act of 2016, and despite the 24-hour education requirement, nurse practitioners and PAs obtain waivers at greater rates than physicians. So I think those data show that these practitioners are really ready to step up to care for this population. Another study that I would point out is one by Amiri and colleagues that was published this year on disparities in access to opioid treatment programs and buprenorphine providers by race and ethnicity. And they reported that residents of American Indian, Alaska Native, minority census Black groups would have to travel a median of 88 miles to reach the nearest opioid treatment program and 17 miles to reach the nearest buprenorphine provider. While other minority or majority sensitive Black groups would travel only 4 to 10 miles for opioid treatment programs and 1 to 3 miles for buprenorphine providers. So with the X-waiver removed, APRNs and PAs who are serving in those rural areas can really participate in helping to serve those populations and expand access to care for persons with opioid use disorders. I also want to mention that registered nurses are key here, and I've talked about that earlier in my comments, but registered nurses total 4.7 million nationwide. a model that was developed called the Massachusetts Collaborative Care Model, was developed more than 2 decades ago. That model was provided to provide support to data physicians by screening and patients for office-based treatment, supervising induction, and working with patients through stabilization. Integrating registered nurse care managers with expertise in addiction into primary care clinics on increasing the uptake of medication treatment for opioid use disorders. So I think with the all of the categories of advanced practice registered nurses who can prescribe, as well as associates, registered nurses, and other members of the healthcare team, including pharmacists, we can really expand access to treatment.
Thank you, Deb. Next slide. Question 2. Physician associates and advanced practice registered nurses play an integral role in the expansion of SUD treatment access. Tell us about the role you play as a PA or advanced practice registered nurse in expanding access to SUD services. How do you see your role in the future? Jim, let's start with you.
You bet. Well, I've a few months ago, I stepped out of my role as far as being a clinician in the opioid use opioid treatment program field. Although I definitely have some clear ideas about this, it's really clear that PAs and NPs play a key role in expanding the access to care. For example, in my role as a PA, I work with PAs and NPs side by side, and we were always encumbered by this, I would say, silly, if I could use that word, requirement that for us to function fully in opioid treatment programs, whether PAs and NPs, we had to have this waiver, and the waiver had to be done by the medical director, and they hated it, and and also by the medical directors and the administration. It was extremely cumbersome, and now that that's no longer required, there's no longer a waiver required for PAs and NPs and pharmacists and the broad array of nurses that Deb has talked about to be able to practice fully to our scope in opioid treatment programs. It's a new ballgame. People are able to be admitted to our programs much more quickly, and without the cumbersome problems as far as like seeking this waiver, which now no longer exists. So I think the removal of the waiver is really going to allow PAs, nurses, and pharmacists to function much more to our scope and to really expand the care that we can offer to people to our patients with opioid use disorder.
Thank you, Jim. Deb?
So I'll say that my focus has been through my professional organizations, particularly the American Academy of Nursing and MRSA, where I've really focused on promoting all of nurses, of all nurses working across the continuum of substance use. I also acknowledge that the opioid crisis has been a primary focus But I do remind providers and our students that in 2023, more than 77 million Americans reported binge and heavy alcohol use. And despite evidence-based medications for alcohol use disorder, in 2019, fewer than 2% of eligible US adults received those medications to treat their alcohol use disorder. So my role has been and will continue to be to advocate for advanced practice nurses to have independent practice across the United States. I want to see the map green across every state and for all nurses to work at their fullest potential. Another component that I think is absolutely essential is the curricular revisions to ensure that nursing students who are seeking to be registered nurses and advanced practice nurses are prepared to care for persons across the continuum of substance use. And in addition to disseminating the results of that work, I'm continuing to mentor the next generation of nursing faculty to lead curricular changes in their schools. So the provision of funding for that work will be important to expand substance use content in nursing curricula across the US.
Matthew, can I add one more thing?
Please.
Thanks so much, Deb, for what you just said. I think that one of the most important challenges as far as being able to meet the needs of our patients in the future is trying to find a way to have PAs and nurse practitioners come together and not just see ourselves as separate entities. I mean, I think historically, at least as far as organizationally, PAs have identified themselves as over here, and nursing and NPs have been over here. And I think the solution, or one solution, is to have us find a way to reject that model and come together and work together, PAs, NPs, and the wide range of the work that nurses do. Because I think if we can come together, we're going to be able to be a unstoppable force as far as meeting the needs of our patients with opioid use disorder.
Thank you, Jim. Thank you, Deb. Next slide. Question 3. What barriers should states consider when developing a strategy to expand the number of physician associates and advanced practice registered nurses providing SUD services? Jim, we'll start with you.
Well, in the state of Washington, one of our barriers is the Washington State Medical Association. And they, I don't know, they've been stuck for many, many years as far as, I guess what they're focused on now is something called scope creep, because they believe that PAs and NPs are trying to take away their power to be all that the Washington State Medical Association and the American Medical Association can be. I think that is a really big mistake. And I think it's a big mistake as far as, because the result will be less care for people who have opioid use disorder. And I think that the PAs and the NPs together and separately are really challenging them and saying, what is the story as far as like scope creep? Because I think they're afraid that we want to take over their profession. So I am very concerned about that. And they've really got to look in the mirror and turn that around.
Thank you, Jim. Deb?
I heartily agree, Jim, with your comments. I think that first, states need to address the regulations that prevent nurses and PAs from practicing at their fullest potential. And for advanced practice nurses, as I showed on the map, even some of the states with independent practice, there are restrictive organizational policies that prevent them from prescribing buprenorphine, and it requires them to refer their patients to physicians who are deemed as qualified providers. So we really need to look at, even within states that are independent, organizations to allow them to practice to their full extent. And I think the other strategy that I would mention is the structural barriers to treatment that continue despite recommendations for integrating mental health and substance use treatment. John Cantor published a 2024 study. He's a policy researcher at RAND, and he identified that only 1/3 of outpatient community mental health treatment facilities in 20 states with the highest opioid-related overdose deaths reported offering medication treatment for people with opioid use disorders. He identified that clinics that offered integrated treatment services for people with substance use disorders were 5 times as likely to offer medication as facilities without integrated services. So staff resources, including RNs, APRNs, PAs in these separate systems could be utilized more effectively in integrated services and expanded. For example, RNs and APRNs with dual certification in psychiatric mental health nursing and addictions nursing, working in integrated settings, have the knowledge and skills to address the health needs of the person with co-occurring disorders. So states can lead more aggressive efforts in breaking down siloed systems and introduce incentives to expand the force.
Thank you, Deb. Thank you, Jim. Next slide. At this time, we will open the Q&A to folks in the audience. If you have not already done so, please submit your question by using the Q&A feature located at the bottom center of your screen. Our first question. Dr. Olson alluded to the concept of patient-centered care. Can you talk a little more about the importance of patient-centered care? Jim, we'll start with you.
Amen. I mean, that's that's a commonly used phrase, which is often, I think, just lip service. And I do believe that patient-centered care is an extremely important thing, particularly with opioid use disorder. For example, when we look at the work that I've done in the past, working in the opioid treatment program, patient comes in and they sit in a chair and I talk to them. And I mean, really, for it to be valuable, I need to fully understand what their needs are. And it's sometimes, I think, very, very difficult and also a very ignored thing to do that. The patient comes in, I talk to them, I say, okay, this, you talk about their concerns and their addiction and their drug use and their opioid use. But if I'm not taking the time to really understand what their life is like, then I'm really missing the boat. And I think that's a boat that is often missed. So I think patient-centered care is, everyone agrees it's important, but I think frequently it's ignored. And so that's something that I really try to do.
Thank you, Jim. Deb?
So I talk about the continuum of substance use, which is from some level of risk of using alcohol and drugs to a diagnosable disorder. I think too often we may emphasize and focus more as providers on the treatment portion, but we also should be focusing on prevention, intervention, and recovery supports. So things, for example, like harm reduction, would be a person-centered approach for the person who's not ready to give up alcohol or drug use. But how can we provide support to them so that there's safety while they're using it and as they go through the process of making their own decision-making, really, which I believe is what patient-centered care is that they are the person they're making their own decisions and they're self-determining what they want.
Thank you, Deb. And as we're approaching the top of the hour, we have time for one more question. Our next question: what's been the biggest lesson you've learned while working as a physician associate or an advanced practice registered nurse? Jim, we'll start with you.
Oh, boy. I don't know. I mean, I've learned a lot of lessons. I mean, I was in the field for, I don't know, maybe 20 years. And one of the things that I really sometimes challenged myself about was about active listening. Because patient comes in and they're pissed off because they're in withdrawal and they don't like our rules, and so I talk to them, and it can be a very contentious discussion, as I think Deb would know as well. And so something I really learned is that just to shut up and just listen and try and listen actively, and and speak back to the patient in respectful ways. And I'm not sure I always met that goal, but I really tried. But because it's really easy to get into this thing where they're mad at you and you're mad at them, and next thing you know they're storming out of your office, particularly in opiate use disorder treatment. So that's something I've really tried to become better at.
Thank you, Jim. Deb?
Certainly I echo that. I think the probably the biggest lesson that I've learned has been from the veterans that I worked with in the VA system. And it was really through my own kind of ignorance of what their experiences were, that I would turn to them and really have them educate me on what their experiences were. And I think that is a parallel to turning to and listening, but then asking the question of, tell me what your experience is like, and really engaging them to understand their lived and living experience.
Thank you, Deb. This concludes our Q&A portion of the webinar. Next slide. Next slide. All right, as a reminder, the recorded webinar and PowerPoint slides will be made available to participants at a date in the near future. Next slide. Along with the webinar recording and slides, there are several provided resources that you see here. Next slide. A reminder that if you have questions to connect with your GPO. Another reminder, for states who are interested in accessing technical assistance, they can do so by emailing the state TA team at samhsaStateTA@jbsinternational.com, or by requesting TA via the stateta.samhsa.gov link. Next slide. And finally, we want to ask that each of you complete our evaluation that you see here. The survey link will be dropped in the chat, or if you have a smartphone, you can access the survey via the QR code that you see here. A reminder that the QR code and the evaluation will be live even when the webinar closes. Again, folks can access the survey via the QR code shown here with your smartphone or by the link that is located in the chat. Next slide. And finally, as we close out for today, a big thank you to SAMHSA, a big thank you to Dr. Olson, and our presenters, Jim Anderson and Deb Fennell. Thank you all for being with us this afternoon, and we wish you a wonderful rest of your day. Thank you.